Back to the Future, a paradigm shift in risk assessment. Today we'll be using polygenic risk scores for advanced phenotyping in clinical practice. First, let's look at cardiac risk and understand that it gives us an opportunity to look at the good, the bad, and the black box of cardiology or cardiovascular risk assessment. And using that as our backdrop, we will proceed to overview the polygenic risk scores and discuss how using polygenic risk scores and dry blood spot testing allowed me to create a precision cardiology pathway in my practice. You might be well familiar with the cardiovascular risk estimators. American College of Cardiology provides a risk estimator for patients in the ages of 40 to 79. It is publicly available. I gave a link here to the website, or you can download it as a mobile app. And you probably are well familiar that it classifies cardiovascular risk into low risk, which are individuals that have less than 5% probability of suffering non-fatal MI or cardiovascular death in the next 10 years, borderline risk from 5 to 7.4%, intermediate risk, and of course high risk, which is 20% or more. The European College of Cardiology has been using SCORE 2 and SCORE 2 older persons to further risk stratify their patients based on age, gender, and actually locations in terms of countries and regions in the European Union. It is well recognized that while the cardiac risk scores are helpful and predictive, they leave a lot on the table in terms of risk estimation. For example, you could see that very young and very old patients may not really receive an appropriate estimate. Secondarily, there are multiple risk-enhancing conditions that are not based on traditional risk factors that need to be taken into account with regard to risk estimation. Moreover, when you look at the cardiovascular risk estimators, as good as they might be to allow us to zoom in on certain broad swaths of our population, these scores continue to be very LDL cholesterol centric. This again should be a familiar diagram where you can see that LDL cholesterol levels figure very prominently in the risk assignment categories, and a lot of emphasis is on starting statin medications or making a decision with regards to use of the statin medications. The scores do recognize that there are gaps or areas where we don't have enough knowledge to fold it into the score. So risk enhancers, for example, are additional features that we can use to apply to understand more granularly what the patient's risk might be, as well as to leverage advanced testing, including Boston Heart Lab diagnostic testing, in our decision making, as well as cardiac imaging modalities such as cardiac CT, for example. The European colleagues have done a great job not just to use typical parameters, and they continue to have LDL-centric scores, but also look at gender-specific models and make those models regional to really calibrate them to specific risk regions across the European Union, which is a very interesting take on the risk scores and certainly allows to apply some of the population-derived estimates to people specifically coming from certain distinct regions, as well as based on their gender and their ethnicity. So what is really bad about cardiac risk estimation? Well, as you know, half of all patients presenting to emergency room with the heart attacks have normal LDL cholesterol levels, and whether you're using an American score or a European score, they are heavily LDL-centric type of scores. There are, of course, genetic mutations that currently we know drive cardiovascular risk. A lot of them do not affect LDL cholesterol levels, and they're not factored in the risk estimates. And there are other biomarkers, specifically biomarkers of inflammation and metabolism, that actually are much more predictive of cardiovascular events than just looking at the lipids levels. Most importantly, these risk scores, and they do predict 10-year risk, are not very precise with regard to the lifetime risk, and they are an extrapolation of the clinical trials, primarily from the era of statin medications and primary and secondary prevention, and as such, they present population level data that we need then to go and apply to individuals, which of course could underestimate or overestimate risk. This is probably the most impactful slide in the entire presentation. We know from the trials in secondary primary prevention for cardiovascular disease, including high-risk patient populations, that only a third of risk is modified by LDL-lowering therapy. 2/3 of the patients in these trials did not get benefit from using statin medication. And so the black box of cardiovascular risk, in my opinion, is here. We know that 50% of coronary heart disease diagnosis presents a sudden cardiac death. Most patients that are found to have coronary heart disease do not have a classic lipid disorder or even elevated LDL cholesterol. As you had seen just a sec ago, more people on statin drugs have cardiac events than not. And of course, advanced disorders or risk-enhancing factors are much more common in our patient populations. For example, metabolic syndrome, elevated lipoprotein (a), markers of inflammation, as well as certain genetic markers that once and again keep on emphasizing that coronary heart disease is actually a familial type of a disease. And we do have an opportunity nowadays to leverage advanced testing to really dig in and guide and individualize patients' treatment. Now, I like this diagram because it brings into focus all the facets that one needs to leverage in cardiovascular risk estimation: lipids, inflammation, metabolism, and genetics. And this talk is actually focusing on genetics because I believe that by using advances in genetic testing, specifically the polygenic risk scores, we can actually redefine the paradigm of cardiovascular risk and use the genotype to actually help us with advancing our understandings of disease phenotype. So you, of course, are familiar with atherogenic lipoprotein universe. There are many of these lipoproteins, and each and every one of them has a normal function in the body, and it's only when they behave abnormally they become a problem. And we know, of course, that traditional measurements are LDL cholesterol, non-HDL cholesterol, ApoB, which quantifies the entire amount of atherogenic lipoprotein particles, are helpful in risk estimates, as well as more advanced measurements, these advanced biomarkers of small dense cholesterol or lipoprotein (a). We also know that we have made some advances in understanding certain genotyping facets of cardiovascular risk. We can use it to predict response to medications, such as statin-induced myopathy, or the benefit that one would derive from using statin medications, and compare the outcome for those who are carriers of these specific mutations versus those who are not. So to illustrate this as an example, if you look, for example, at KIF6 statin benefit, these are the individuals, and if they are carriers across the range of statin trials, they have demonstrated enhanced benefit in risk reduction with a statin medication. So we know very well, and that's again from all the trial data, that risk reduction in coronary heart disease is not uniform. And it's important to identify patients who are likely to be more responsive to these medications, where these medications are likely to significantly affect their heart attack risk. And in the trials, carriers of KIF6 were benefiting more from the statin treatment, and non-carriers were benefiting less. And therefore, just one mutation, carrier mutation, heritable mutation to germ cell lines, can actually affect an individual's potential to benefit from statin medications. But is this really enough? Recently, polygenic risk scores have really came into focus and became available for clinical applications. And to understand polygenic risk scores, we have to pull back a little bit from individual variants such as KIP6, for example, or 9p21, and realized that many more genetic markers are predictive of cardiovascular disease or atrial fibrillation or propensity for early menopause, breast or prostate cancer. But the effect of these genetic markers might be very mild. So while adding them together across thousands, if not millions, of different genetic parameters, one can then plot a population in terms of polygenic risk score. And I don't know if you could see it in the diagram, but from low risk to high risk, there's a gradation in terms of color. And of course, the persons at the high risk in these red bubbles certainly are the ones who are much more likely to have coronary artery disease or an event that the polygenic risk score is forecasting. So let us take polygenic risk scores for a spin, and hopefully you will be convinced by my assertion that polygenic risk scores will redefine how we see cardiovascular risk phenotypes starting in clinical daily practice. Let's take a look at this lipid profile, and I'm only going to give you a lipid profile. I have no history for this patient or physical exam data other than the fact that he does not have known coronary artery disease. This is a 37-year-old male, and if you look at his lipid profile, you will probably not going to be super concerned. Sure, he has areas for improvement, but overall his lipid profile appears to be fairly acceptable, and perhaps with lifestyle modification he could achieve green light for LDL cholesterol ApoB and even improve his HDL-C and ApoA1 number. However, if you look at his polygenic risk report, this individual, who's only 37, is in the 88th percentile of risk and has a 46% lifetime risk, which is 3 times the population mean for developing coronary artery disease. Unlike a single SNP that I showed you in the prior report, this is from nearly 2 million genome-wide variants that have been assessed to derive at this risk. So what that actually means is that even though he's only 37, sometime in the next decade or so, by the time he approaches the age of 50, he will start to accrue a much higher risk of coronary artery disease, non-fatal myocardial death, than people who are in the low end of polygenic risk score estimate. And so his risk threshold is 3 times of what would be just the normal population distribution. So what would you do for that patient if you only were to see his lipid parameters? You would probably just counsel him with regard to lifestyle modification and perhaps not proceed any further. However, seeing this particular circumstance and his high risk based on polygenic risk scores, you most likely will refer him for additional workup. There was a very interesting study recently from Denmark, a prospective observational study on looking at younger patient group, ages 40 and older. They were primarily Caucasian, and the study used cardiac CT to find subclinical atherosclerosis. What they found is that 46% had evidence of subclinical atherosclerosis. About 10% or so had extensive disease, defined as disease in at least a third of the coronary tree, coronary vasculature. And that group, mortality from heart disease was 8 times higher than those who did not have any subclinical disease. So you could see how this is likely to reshape how we practice cardiology and how we begin to see the genotypes of cardiovascular risk as the foundational component in understanding the risk phenotypes. Who needs to go for advanced imaging and who can be managed more conservatively. Now let's take another spin here. Here's an individual, it's a 58-year-old woman, and her polygenic risk scores look pretty average. She does not have an increased risk. And again, this is based on nearly 2 million variants that were examined, but that's her cholesterol profile, right? Certainly this is not a cholesterol profile where you would just sit back and relax, even though her polygenic risk scores are essentially normal. This is someone who you would work up further for the reasons why this lipidemia is occurring. And there could be reasons that have to do with familial predispositions. There could be reasons that have to do with thyroid abnormalities, hormonal abnormalities, acute phase reactants of some sorts, perhaps insulin resistance. So there is a lot of opportunity here to make a difference for this patient. But interestingly, her genetics, her polygenetics, does not really code for an increased risk of coronary artery disease. So you probably have a little bit more wiggle room here with this patient than you had with the previous patient who's 37, whose numbers looked much better. And so in my practice, we use what I call a precision cardiology pathway, and using history and records and prior testing, we'll leverage Boston Heart Lab, dry blood spot, and genetic testing kits, and I actually have it labeled as Heartwell Toolkit for my own applications. And we collect this data and sometimes epigenetic data to actually create personalized and actionable plan for heart and vascular health for our patients. A lot of good effort is underway nationally through the National Human Genome Research Institute that actually uses vast amounts of data and DNA biorepositories and electronic medical records to create genomic risk assessment and relate it not just to clinical determinants, but to social determinants of health, monogenic and polygenic determinants, as well as the family history. And I'll be happy to take any questions at this point.